As a psychiatric nurse practitioner, what I do is I meet with people and I focus on two things. We are considered sort of subject matter experts in psychiatric diagnostics and also prescribing psychiatric medication and then ongoing medication management. There's so much power in psychoeducation, and sometimes just having an understanding of, oh, this is anxiety, or oh, this is ADHD, can be really healing in and of itself. And we may not even really need to talk about medication.
Welcome to the Four Peaks Parents Podcast with Thomas Miller. Are you tired of your tweens, teens, and young adults' negative behaviors and poor choices holding you emotionally hostage, controlling your family, and ruling your life? If you answered yes, then you are in the right place. This podcast is a community for courageous parents just like you who come here to gain effective tools, skills, and take action so they can change their tween, teen, or young adult's life and improve their family's future. Welcome back to the Four Peaks Parents Podcast with your host, Thomas Miller. I'm so excited to have with me a friend and a great colleague and an amazing resource, Carly Ramos. Welcome.
Thank you so much for having me. I'm excited to be here.
Yeah, I'm going to do a quick intro of who Carly is. Carly is an RN, an MSN, a PMHNP-BC. She's got acronyms for days. She is a board-certified psychiatric mental health nurse practitioner at Safe Harbor Psychiatric in Newburyport. She's highly regarded for her expertise in autism, having been awarded a prestigious autism fellowship at Boston Medical Center in 2018. Carly also serves part-time at Massachusetts General Hospital's Allen and Lorraine Bressler Clinic and Research Program for Autism and ADHD, where she contributes to both clinical care and research initiatives. She is the owner of Safe Harbor Psychiatric in Newburyport, and we share so many clients, and she does an unbelievable, amazing job, both herself as well as building a high-performing culture where she has brought in, please correct me if I'm wrong, 3 nurse practitioners as well, correct?
Yes, we have 3. It's myself, and then we have 3 other nurse practitioners, and we do have a therapist who's right now only available to clients who are accessing medication management with one of our nurse practitioners. So we have a little bit of additional capacity to kind of support some of the therapeutic needs in addition to just the medication management for those people who are looking, which is really nice to be able to kind of offer a more complementary supports than just the medication piece.
And why I have Carly on today is that I am so happy to have amazing people in my network, and my role as the host here, of course, is to know a thing or two. I think I know a few things. There's a lot I know. There's a lot I definitely don't know. And I know what I know and know what I don't know. And so I'm always trying to create opportunities, right, for everyone listening at home to learn more and be put in front of you, subject matter experts like Carly. So today we're going to talk about all things meds and all things, obviously, mental health beyond just medication. And the coolest thing I'd say about Carly and her team is that they have an amazing bedside manner, and they absolutely know how to engage and build wonderful therapeutic alliances and relationships with their clients. And her and I arrived at the same time, like 2020 in Newburyport, right?
We did. Yeah. I think I was just here a couple months after you'd been in town and set up your practice.
Yeah, it was January 2020. Yeah, so we both arrived right in the heart of COVID. Yeah.
Yes.
Good times. So one of the things, and we'll go like wide to narrow, I think of this as kind of a funnel, just so we're leaving from the same station. Can you do a quick little PSA of, what you do and how are you different than, say, a licensed clinical social worker like myself, or how are you different than maybe a primary care or psychiatrist, and what really is your role, and give us like a typical day-to-day, and speak about all the amazing value that you bring to your clients.
I am so glad that you asked this question because we have a lot of people that don't know what a psychiatric nurse practitioner like myself is or does. And arguably, it's very confusing. There are a lot of different mental health professionals. And unless you really exist and live in the space and have, the higher level of education to understand the different facets of mental health care, it's hard to know who does what and who do I go for therapy, who do I go for meds, and how is a psychiatrist different than a nurse practitioner, different than going to my primary care doctor. So, as a psychiatric nurse practitioner, I think it's probably the most helpful to start with what is my education. So, I hold a registered nurse license. To become a psychiatric nurse practitioner, you have to have a bachelor's degree in nursing and you have to carry a license as a registered nurse at all times. I did a 4-year degree to get my Bachelor of Science in Nursing. And then to become a nurse practitioner, we're considered advanced practice nurses. And that is an additional master's degree, which you can do in about 2 to 3 years. I did it in 2. So in total, I have 6 years of education that has allowed me to become a nurse practitioner. I had to sit for a second board exam to get my advanced practice nursing license to become a nurse practitioner. So I have to have 2 licenses at all times. I always have to be licensed as a nurse practitioner, and I always have to be licensed as a registered nurse to be able to function in the role that I function in. As a psychiatric nurse practitioner, what I do is I meet with people and I focus on 2 things. We are considered sort of subject matter experts in psychiatric diagnostics and also prescribing psychiatric medication and then ongoing medication management. So I have some people that will come to me because they're sort of questioning maybe a specific diagnosis or they're experiencing a lot of mental health symptoms. And they're just kind of looking to sit down and have a conversation with somebody about what their experience is and to see, is there a diagnosis there? Are these clinically significant symptoms? And just trying to understand a little bit more about themselves. Because, as I'm sure you know better than anybody, there's so much power in psychoeducation. And sometimes just having an understanding of, oh, this is anxiety or, oh, this is ADHD can be really healing in and of itself. And we may not even really need to talk about medication. So sometimes people come to us just because they're looking for a diagnosis or clarity around what their symptoms that they're experiencing might be or might mean. Many times, if there is a diagnosis there, we'll also talk to people about medication options for treatment if we feel that it is appropriate. We also have some people who come to us specifically looking for medication consultation. So sometimes these people have previously had a diagnosis. Sometimes people come to us, they're already on medication and they want to continue what they're taking, or they have questions, they want to make changes, or they might be looking for a second opinion around the medications that they're taking because maybe they're not working really well, or they're having side effects, or they're other life things like planning pregnancy and wanting to just talk to a subject matter expert around safety and efficacy, sort of moving forward with their treatment. So those are kind of the main things that we focus on. We at our practice at Safe Harbor Psychiatry, we don't do psychotherapy. There are some psychiatric nurse practitioners out there who will do medication and therapy. I refer people to folks like yourself because I think that there are way better people out there than myself to do therapy who have much more extensive training and expertise. And I feel like, our strength is really on the medical side in terms of managing the medications and the side effects. So that is sort of the lane that we like to exist in, but we partner with folks such as yourself to do the complementary therapy coaching for our clients who are receiving medication services at Safe Harbor.
And I think that's such a good point around the idea of collaboration. One of the things that it's interesting, when working with parents, it feels like they have an either or perspective on so many things, as opposed to that things can actually be beneficial, right? Or things can concurrently work. I've shared on this podcast a couple of times, having been a founder of Innovative Therapy Solutions. That was the center my wife and I created in Great Barrington out in the Berkshires. It was interesting that families were way more apt to consider acupuncture or yoga or cupping or qigong or tai chi or hiking or whatever. And now moving out here, it's interesting how there's more receptivity, I think, toward medication management. Not to say that there was no openness in the Berkshires, but people were more open toward more holistic approaches. Not to say medication is not holistic, but it's not either or. And I think the piece around, as you put it, collaboration is so important. And that's one of the things that the reason why I send so many folks your way is because you do that, as does your team, so well, and that we have really great conversations and we're able to, you know, each one teach one in essence, right? Make sure that the right hand knows what the left hand is doing. And, speak to maybe how you help broaden yourself beyond just simply the med provider, even though that is the lane you exist in and you're so good at it. And the piece you spoke about too, which maybe is like a second question, is this idea of like establishing a really good starting point. Diagnosis is just a great starting point, and from there, all treatment needs to flow from a really solid assessment. But how do you play educator? How do you play, in addition to, which is super vital and super important, the idea of course, starting with a great clinical assessment and a great diagnosis, and then having really good treatment begin vis-a-vis medication. How else do you also play that role of educator for families?
Sure. So, everybody who comes to see either myself or one of our nurse practitioners at Safe Harbor, everyone is going to get a clinical intake assessment, whether you have had the most comprehensive neuropsych exam and been diagnosed and feel connected to a diagnosis forever. Not that we're, trying to poke holes or disagree with a diagnosis that somebody feels really connected with, but we always make sure that everybody who comes to the door, you get a brand new, fresh set of eyes, a new clinical assessment. And we oftentimes come up with some other things that maybe people hadn't really been cognizant of or hadn't necessarily identified as being maybe rooted in ADHD, or we'll kind of say, hey, I wonder if there's some neurodivergence here as well. A thing that I think also might help to provide some context is we rarely are getting people who are walking through our door who have never seen a mental health care professional or have not talked about this with a primary care provider. So most people have done some sort of preliminary exploration into their mental health, whether it's been therapy, whether it's been some medication trials with a primary care provider, whether they've had some neuropsychological testing done or worked with a school counselor. So, a lot of people are coming in with some sort of information, whether it's accurate or inaccurate, positive or negative, about psychiatry, their mental health symptoms, medication. So the education piece of what we do is huge. And that's why, we try to make sure everybody gets a fresh set of eyes, a new clinical assessment, where we're really, really going through and we're doing a very, very thorough history taking from birth until what are the clinical symptoms you're experiencing today. And then from there, we'll either formulate a diagnosis or a hypothesis as to, I think that you might be experiencing these symptoms because of X, Y, and Z factors. And we use that opportunity, especially at the first appointment, to then do some psychoeducation as to, like, what is anxiety? What is the spectrum of ADHD? What is depression? Can irritability be a symptom of depression? Something that not a lot of people might necessarily associate with a diagnosis such as that. And then from there, again, if we feel that medication is clinically appropriate, we will kind of talk to people about what medication options might look like and try to educate people as best as we can around the different classes of medication, why we're choosing a specific medicine based on the symptoms that they're presenting with, and then certainly going through side effects, risk versus benefits. And then I think the most important thing is, or two most important things about that is, we make sure that we're trying to have realistic expectations with people about what medication can and cannot do.
Hmm.
And
Hmm.
then also outlining for them, what does follow-up look like? What
Hmm.
does ongoing monitoring look like? We don't just say, okay, you have depression, here's your medicine. I'll see you in, 3 months and we'll talk about it then.
Hmm.
We want to make sure that everybody has a really solid understanding of what we're hypothesizing the mental health symptoms to be attributed to, whether we have a diagnosis at that point in time or we have a working diagnosis, and then have a really good handle on, why we're recommending medication. What is this medication supposed to realistically do? What can we expect from the medication? And then how are we going to continue to evaluate that ongoing? So, I think that more than 50% of what I do actually ends up being in the realm of psychoeducation and education. And then one other little thing that we often find ourselves as psychiatric nurse practitioners speaking with our clients about is navigating the mental health care system. Teaching them an LMHC versus a licensed clinical social worker versus a psychologist, and how to access different levels of care, partial hospitalization, inpatient level of care. We're so fortunate in Massachusetts. We actually have a lot of really, really incredible resources of all different levels of care for several different mental health diagnoses, but no one really knows how to access them or that they exist. So that's another thing that we
Yeah.
find ourselves kind of being a part of as well.
Well, I mean, that's definitely another episode about the mangled care system, and
Well, we could go on and on about that.
yeah, yeah. I mean, it's why it's, and I want to piggyback on a couple of things you said, but I just want to say one thing about why I built the Four Peaks Parents Program is that it's a results-driven program to take families on this journey across four peaks. The first peak being the family audit, which is ostensibly where are we, how did we get here, what is healthy, what is dysfunctional. The second peak being emotional mastery, helping the parents to become the masters of their own emotions so that they're not emotionally dysregulated and further creating more emotional dysregulation and being unflappable amidst their kid's storm. And then the third one is upgrading their toolkit. And then the fourth peak is we end with rewriting your family story. But really what I'm doing across those 90 days with those families is being the Sherpa and the guide and helping them to figure out what is popping in that system from a mental health or addiction perspective. Is there a co-occurring disorder going on? And how do we send those mental health symptoms to the background and culturally create tips and tools and strategies so the families can really know how to immediately move that culture forward. And so often I am playing quarterback and helping families figure out what is the right level of care, because what is so hard and for families, I just had a discovery call yesterday for a Four Peaks parent program, is the teen went to a therapist, and then based on confidentiality, which I completely understand and respect to a degree, it doesn't sound like this therapist was utilizing though the family system as much and was being marooned on an island. Everything becomes, as piecemeal. And one of the
Hmm.
things I liked about what you said is that while you're not dismissive or disrespectful or of the psych test, neuropsych, the previous clinical diagnosis from a PCP, whomever, you start afresh. Because, the reason I love working with you and love working with your team is that you do look at systemics, right? You do look at root causes. You do look at what is the driver versus simply the symptom. And I think what's so frustrating for me, and that was the reason why I built this program, again, to give parents tools in real time that they can actually take the health of their family back. They could take power back today. They can make a shift today that will literally change a diagnosis. Like, people a lot of times don't understand that the diagnosis at initial is not the diagnosis at discharge. And that's if things go well, right? So when I
Right.
was the family wellness director at Mountainside, and clients were coming in with a whole host of co-occurring issues, both mental health and addiction, they were leaving with a better diagnosis, if you will, a more milder version of symptomatology. But it goes the other way, as you know, right? How many families or clients have you worked with where families have kicked the can and asked that child to metastasize those symptoms to basically get their needs met? So they have to up the
Right.
ante. And then we're dealing potentially with characterological issues where we're having to talk about access to, which is
Right.
personality disorders that we could definitely talk about in another episode. But to come back to the piece around, the education, what I love about how you work is that there is an accountability on the parent side, and maybe you could speak to that. Like, what, as someone that at times I know I get parenting exported to me. I've gotten over the years of my career, having worked with a tween, a teen, a young adult, the families are like, cool, I got this great therapist, check, job done. And I'm like, no, 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 roll up your sleeves, right? Each one teach one. We're all going to get, jump out of the cheap seats and get in the arena. How do you help keep families engaged so that there's a responsibility and accountability on the family or parent side? So it's not simply just cool, my kid took my med and job well done.
Right. And it can be really challenging. I think what I found is especially with working with children and teens is you bring the family in and you set the expectation that they're a part of the treatment from day one. It's very hard to walk it back later
Mhm.
in treatment when you don't involve them right off the cuff.
Mhm.
And, one of the things that we try to do is we try to empower parents rather than disempower them. And we do, get a fair amount of people who come and say, I was working with this other person and, they, were just kind of sort of poo-pooing everything that we were doing. And maybe everything that they were doing wasn't the best thing, but, we have to remember that, like, parents are out here trying to do the best that they can every single day, and, these kids are really suffering and they're having trouble or else they wouldn't be in my office.
Mhm.
And there's no one has a handbook on how to parent perfectly, and certainly there is no handbook on how to perfect maybe a really difficult child, a
Mhm.
child who might be dealing with bipolar disorder,
Mhm.
a child who might have attachment issues, who might have experienced some sort of a trauma. It's really, really hard. And I think it's important that we as the providers are able to empathize with the challenges. And again, instead of sort of shaming and saying, well, you shouldn't be doing this, you can't be doing that, to motivational interviewing, I think is something that we try to incorporate a lot, is to just sort of try to reframe that and say, yeah, this is really, really hard, but you don't have to go it alone. There are great resources out there, and I'm going to count on you to work with me to help your child to get better, because the only way that this kid is going to get better is if we all work together as a team. The kid can't heal themselves. I can't alone heal the child. You can't alone heal the child. We together have to heal the
Mhm.
child. And so, bringing everybody in at the first visit and kind of setting that expectation that, like, this is a team effort, I found to be the most successful
Mhm.
in sort of getting parent buy-in and in adhering to at least the medication treatment plan.
Mhm.
We're also very, very, very big advocates of parent coaching and parent strategies. Again, for the reasons I said, parenting is really hard, and kids who are struggling with mental health issues are even harder to parent. So we are often referring out to folks like yourself, or other, online resources, books, just so that parents can have more resources and get more education on, how to affect some of these behavioral modification strategies that are just going to help the medications to be that much more successful and
Mhm.
effective in the long
Mhm.
term.
Yeah, and I think it's so hard sometimes for families to understand that some things are episodic, some things are chronic. How do we not live in the crisis, right, and not attenuate ourselves to, waiting for the next shoe to drop, but also coming to terms with that things are different. You mentioned the word neurodivergence. I've mentioned that a bazillion times on the show. And just to clarify, right, that would be clearly someone who would be on the autistic spectrum, ADHD, even dyslexia, right? There's that term is being brought into every day. And so it's really nice when you talk about that engagement on the front end and the empathy and the compassion that you're flowing to parents when you have families that are now starting to change perceptually a little bit how they're viewing their kid. They're not personalizing every little thing. They're not thinking this their child's just quote unquote lazy or
Out to get
oppositional.
them.
Yeah, out to
Yeah.
get them. And again, they're not mutually exclusive. I mean, it goes
Right.
the other way too. So many times with families, I'll say just because your kid is autistic doesn't mean they can't be manipulative. Just
Right.
because
Right.
they have this mood dysregulation disorder, it's great that you're flowing empathy around this or that being hard, but we also don't want to allow that OCD child or that social phobia child to basically hijack the norms of the household, and you're doing
Right.
nothing other than providing them with the psychological backdoor, which is only going to exacerbate those symptoms. And we do have to ask them to lean in, but it is nice when you can do that, and I think you do that very well, like you said on the front end, so that it takes a village, but it also disarms this idea of and destigmatizes, of course, mental health. And I've seen such a shift. I was actually joking with a client the other day who asked if they could pay in cash, and I haven't been paid in cash in forever. And this is actually a true story. When I first hung my shingle way back when in 2004, I was in Pleasantville, New York, which is outside of, it's in Westchester County, outside of New York City. I had a bunch of men who would pay me in cash because they didn't want any paper trail on their credit
Right.
card just for coming to therapy. And they would like shake my hands at the end of the session, and then like there would be cash in my hand, and I always
You're,
felt
you're
like
doing a
dirty. Like
nefarious
what am
deal.
I like I feel like I'm a stripper or something. Like why do I have I'm coming home with like all this cash. It was so bizarre. And it wasn't even anything. I'm not even talking about, I had tons of men, of course, who were on the quote unquote down low, about, not out about their sexuality. So
That's
things
funny.
have changed. I mean, what are some, and of course you mentioned anxiety, and, we had a great show, a couple of shows back with Katie Greer about just the impact of tech and what we as parents need to do and how to support and have just, oh my God, better thinking around how we're helping our kids navigate. What are you
Right.
seeing as kind of some major drivers right now that is creating a lot of challenges or issues for kids, or what are just things that you're seeing that maybe feel different or new or anything?
Social anxiety is huge. And I started my NP career in 2018. So I don't have a ton of pre-COVID experience, but social anxiety, I think, is something that a lot of people have historically really struggled with. And then after COVID, kids really stopped knowing how to function and how to reach out and how to connect with their peers, and have so much internalized negative self-talk. They feel judged everywhere they go, and it really is something that can be debilitating in a lot of ways. And sometimes that looks like school avoidance. Sometimes that looks like we're not reaching out to any of our peers. We're not leaving the house to socialize. Most kids feel okay to socialize from behind a screen, but even then, we've had some more extreme cases where, texting a friend is really overwhelming, or answering the phone, talking to somebody on the phone. So that's something that we're seeing a lot, is just this really intense social phobia, and then just a lot of cognitive distortions around, what our peers or what other people in our environment may or may not be thinking about us, and believing those things to be true. And as you know, I'm sure anxiety is manipulative, especially aggressive anxiety. It makes you believe things, and it's very, very hard to dispel those truths at times, but not impossible.
Hmm.
Therapy is super, super helpful, super, super effective. And that's where, for a lot of the kiddos that are coming in with the social phobia, we'll talk about medication, but therapy needs to be a part of that equation as well, because the medication isn't going to teach you how to challenge those cognitive distortions, or it's not going to teach you about core beliefs or any of those other like great CBT and DBT skills. The therapy might help those to become more accessible in working with your therapist, and for you to be able to access those coping skills in the moment when you are faced with a socially stressful situation. So we're seeing a lot of social phobia, and I would just say anxiety, generalized anxiety in general. With the political environment,
Hmm.
kids are involved, which is wonderful. I, you know, could care less, or didn't really know what was going on in the world
Hmm.
at,
Hmm.
16, or
Hmm.
even we have 11, 12-year-olds who are really,
Hmm.
really care
Hmm.
about the world. But that's also seeming to create a lot of anxiety and
Sure.
stress. And so I would say anxiety is probably the biggest thing that we're seeing and we're treating with kids. And I think that anxiety drives depression as well. So oftentimes there are
Hmm.
flavors of depression in these
Hmm.
kids with really, really high anxiety.
Hmm.
Um, and of course, we see OCD,
Hmm.
ADHD, some bipolar. But, I think people can live with depression and even live with, some unstable mood symptoms, but anxiety is incredibly uncomfortable. So we'll find, like, people will sort of muscle through depression for a while, but once the anxiety hits, it's really overwhelming, and people are more likely to seek out, I think, medication
Yeah.
solutions when they hit that stage.
Well, and I think because you treat a lot of teens, as do I, of course, and a lot of the families that are part of the Four Peaks Parents Program have teens. I also have tons of young adults, parents as well, and kids that are sort of in a way presenting, developmentally. They're kind of at a fixation point. Their age might be 21 or 22 or 23, but they're presenting. Biologically, they may be at X age, but developmentally presenting this way. But for teens, as you spoke to, the piece around cognitive distortions, just to clarify, just so not clarify, just so folks know what Carly's talking about there. It's the way someone's thinking about themselves or thinking about the environment, and it's almost that they're like porous. It's almost like that they're an X-ray. If you think about teens, the social stock is going up, the parent stock is dropping a little. Still super important though, parents, no matter what the hell your kids say, you are definitely the most important asset and protective factor kids have. But the social stock is going up. And so, yes, if someone is rather thin skinned, like I think of a Pinot Noir grape is a thin skinned grape. And teens are Pinot Noirs, I mean, they are,
Mhm.
they are super thin skinned. And the other night I said to this girl, I was like, girl, you don't even have like hemoglobin. Like, I'm like, if I like cut you, if you had a paper cut, you would bleed out right now, honey. I'm like, you are an emotional hemophiliac. I mean, like, we need some
Yeah,
emotional clotting. We got to figure that out. And
right.
some of those tools that Carly mentioned, DBT, CBT, those are evidence-based things that, of course, I'm trained in and offer folks and help families even do some work through the program around how do you change a kid's perception. Not everything is a freaking 10 out of 10, and how do they put a healthy pause between impulse and action? How do they take emotional distance from that? So you're saying or seeing that, anxiety is really a predominant thing. And I think your piece around COVID is so true that, and again, that's where I come in and try to be, I think, a little disruptive in the sense that I do want parents to put kids in uncomfortable situations. I'm not talking drama, drop off the 9-year-old in New York City and say, figure it out. But there is this, yes, there's been this pause button in a lot of kids' social development. And so if we recognize that, we do have to at times ask our kids to do hard. We do have to, of course, coach, prepare, help them level up. And anything from, yes, talking on the phone, like you said, or going actually in person in RL, this thing called RL. Oh my God.
Is that what the kids are
And
saying?
yeah, and versus
Oh,
VL
that's
and
funny.
actually going on a job interview and actually
Right.
talking face to face and so on and so forth. I have a couple of cool questions actually that I got
Okay.
from and in the description of this show there will be of course great ways to reach out to Carly and her team if you'd like. I'll have list their website and other ways to get her, as well as there is the newsletter. And so this comes from the newsletter, which I'll kind of simplify it a little bit. But someone said risperidone is super effective, but the weight gain sucks. How do you manage the benefit of a med against when kids can become self-conscious about that? And before you answer, I just want to say one quick thing. And so risperidone, just for folks listening, and Carly, of course, could speak more eloquently than I can, but as an antipsychotic med that has, as this person is speaking to, some negatives. And so when a child, right, is needing to address, as I call it, the gunshot wound, it's like more often than not early on in treatment, we're kind of triaging. We're dealing with the gunshot wound versus maybe the sprained ankle. So how do you balance out not just risperidone, but in general, and you could speak to risperidone, of course, but how do you balance out those pros and cons? How do you try to figure out, if this, then that, what comes first, the chicken or the egg? And where do you go with situations like that?
Yeah. So, as we all know, no medication comes without the potential risk for side effects. And some medications have a higher side effect profile compared to others, and some have less desirable side effects compared to others. So, we are constantly looking at the risk benefit ratio. We understand that if we're going to be taking medications, there is the potential for risks. There is the potential that it might not work as anticipated. There is the potential that we might have an allergic reaction. There is the potential that we might have some side effects. So, we're constantly reevaluating, do the benefits of this medication outweigh the risks? And when I'm talking about benefits, I'm talking about improved quality of life, which is very broad, and is very different depending on what the diagnosis is and what, the agreed upon treatment outcomes look like. When it comes to metabolic side effects, that's something that we take really, really seriously, because weight gain can lead to high cholesterol, high blood pressure, and then we're looking at, some more significant health issues. And my spiel to people is, I'm not here to swap out one problem for another. That's not what I'm trying to do. I don't want to, regulate your kid's mood, but now they have type 2 diabetes. So, one of the things that we do, especially if there is a concern about metabolic side effects with a medication, is we partner really closely with primary care to make sure that we're monitoring weight. We do a lot of blood draws, and we see that we're sort of trending in a direction where, we're concerned that we might start to have some of those associated negative metabolic syndrome symptoms, like the high blood pressure, high cholesterol, high glucose. We kind of have a conversation about, okay, are the benefits still outweighing the risks right now? And there's always something that we can do. And sometimes we reduce the medication. Decrease exposure to a medication typically decreases the side effects. Sometimes we add in medication to offset the side effects of another, which sometimes is a little bit of a hard sell. But again, benefits outweighing the risk. If the medication is
Mhm.
really stabilizing and life saving, can we add something in to offset the weight gain or the high blood pressure, so that we can safely remain on this medication that's really helpful? Sometimes we switch. We say, you know what? No, it's not. Even though this medication is really helpful, we've gained a lot of weight. Not only are we worried about some of the metabolic side effects, but self-esteem is not so great
Mhm.
because we put on a lot of weight. And again, we're not here to swap one problem out for another. Oh, now my mood's stable, but now I'm really self-conscious.
Mhm. Mhm.
Then we're not achieving the therapeutic goal. So we're very open-minded about, okay, maybe we need to switch to a different medication, and let's try to choose something that will hopefully work as effectively as whatever this thing is that we're on, if we like it and we feel like it's helping, but might have a lower incidence of weight gain, a lower incidence of increased blood sugar. So,
I think and the thing that I know you do so well, and I think is so important, is to have those dialogues and to not have a one size fits all approach. And once, just because you're on one direction, I say all the time, particularly to young people, they drive me nuts right now. All these young people are so absolute thinkers. They're so black and white. And I'm like, aside from cutting off your head, like everything's a freaking two-way decision if you really think
right.
about it. There's no one-way decision in terms of, if I'm on medication, I can go off medication. Obviously, you should do that in a safe way and be, medically monitored when you do that. But families, understandably, they have a lot of fear about this or that. And, I'm always trying to help families, realize that myself, or of course, someone like you, would be a tailor, right? There's no one I would put in front of my families that I wouldn't trust with my own children's care. And so that idea of, yes, having these very multiple touch points and being very proximal and encouraging the client to be proximal. I think what happens a lot for a lot of our clients is they become so externalized. Everything is symptomatic, and so they're not
Mhm.
really integrated, which is why, obviously, when we had our center, we had a yogi on staff who actually had an MSW, we had an
Well, that's
acupuncturist,
great.
we had a med prescriber, we had a clinical team. And then same thing in the Four Peaks parents program. There's a whole series in the Upgrading Your Toolkit where I'm teaching parents in real time how to take space when a child is spinning, or how to help ground that child in real time, or how to, again, co-regulate, or how to ostensibly get that neuronal feedback loop to basically shift or
Mhm.
change the channel. So this idea, again, if it's not one directional, and a lot of times families, that's what I was kind of saying about the Berkshires, it just was funny. A family would be burning sage metaphorically and doing qigong or tai chi, but I would go on this badass hike, which is really cool, and I'm the biggest fan. Sleep is medicine, the woods are medicine, in my opinion.
Mhm.
So is food, so is community, so is any kind of art or expressive things or athletics. But then it's funny now treating folks in Newburyport, not to say that everybody's seeking the pill, so to speak, but there are folks that are seeking things that are more external and not looking at what's right in front of them. So again, nothing is mutually exclusive. And I think you do
Right.
such a great job of helping the parent and or the child or the teen or the young adult, right, feel in charge of their own care and also take their own internal temperature and be able to move with this changes that are happening. And then you can kind of make those decisions, based on, like you said, the pros and cons and really weigh it out, and not feel like, okay, now we're going in this direction. We only have to go in this direction and we can't, make some changes. The other thing too, that just
Right.
speak to, it cracks me up when someone comes in for an intake. It's a therapy client. I'm like, what medications are you on? Oh, I'm on Zoloft. Oh, I'm on, whatever, Lexapro. When was that, prescribed? 2012. It's like, wait, what? I'm like, that's not working. That's just not working. And it's interesting because you'll see folks that, in my opinion, shouldn't be on any medication and are just holding on to it from a security blanket standpoint.
Mhm.
And it cracks me up, when someone's like on 20 milligrams of Lexapro and they're like, oh, it's totally making a difference. Meanwhile, based on their weight and the fact that it was prescribed in 2003, like there's nothing going on most likely
Right.
there. So that's always an interesting one. How do you help folks maybe that are wedded, right, to certain solutions? How do you help expand their worldview and get them to be a little more open to either a new medication, a new trial, a new approach? How do you do that?
That's a great question. So, and we see this a lot in multiple perspectives. So sometimes if somebody's on a medication and I kind of think, maybe we're ready to come off, or maybe we don't need this medication anymore. That's a conversation that I'm regularly having with people. So just generally, the way that I like to practice is once somebody has been really stable on medication for a year, in most cases, not all cases, but in most, I like to open up, hey, do we think that we could maybe try surviving on a little less medication? And what do you think about that? And we start to kind of come up with maybe a plan for very slowly titrating down to kind of see, like, do we still need this medication? If we do, can we survive on less? Does, that 20 milligrams of Lexapro that I've been on for 10 years still need to be there when my life has changed so much and I've gained so many skills and learned how to manage my depression, my anxiety? Do I really still need 20? Maybe I only need 15. Maybe I only need 10. And we really try to reassure people that, we're here to walk them through that process of stepping down off of medication. We go really low and slow,
Hmm.
and there's always the option to go right back up to the dose.
It's you should call that the barbecue. You should call that the smoker principle.
I know I
Slow
gotta
and
hire you
low.
to come up with some good taglines for for my process.
I have a smoker and I do 12-hour ribs, slow and low, really good. So no, that's good. Yeah.
Yeah, so we, we step back slowly off medication and we hold, right? We're not,
Hmm.
okay, we're going to take you off of this in 3 weeks and then
Hmm.
go function and be fine.
Hmm.
We talk to people about what are some things that could happen with reducing medication, and are those things necessarily going to be reasons to go back up on the medicine, or are those things that maybe we could work through so that we can kind of continue with the overall goal of living on less or no medicine? So when we have people who were really feeling like, I think that we're ready to kind of survive on less medication, that's sort of the approach that we like to take.
Hmm. Hmm.
Um, and then we have people who come in who feel really connected to a medication, but they're so symptomatic and they're talking
Hmm.
about
Hmm.
how impaired they are in their lives.
Hmm.
And what we try to do is be a little bit of a mirror to reflect that back and
Hmm.
say, you know you're on the highest dose maybe of Prozac, and I'm glad you're not having any side effects, but, I think that we could do better. If we're on 80 milligrams of Prozac, but, you're still spiraling at night and taking 2 hours to fall
Hmm.
asleep, I don't know. I think that if we're gonna be on the highest dose of medication, I think you deserve to see a little bit better.
Hmm. Hmm.
What are your thoughts on trying something that,
Hmm.
might
Hmm.
actually
Hmm.
work for your symptoms that you're telling me are really getting in the way of your quality of life? And exploring, why are you so connected to this medication? What is
Sure.
it about this medicine? What are your fears
It's their
about
love
switching to
affair.
something new?
Don't you dare
Yeah.
take my Wellbutrin,
Yeah.
Carly.
Yeah. And then again, Yeah, we don't prescribe in absolutes. Certainly there are some people where a certain medication might absolutely be not a good idea because you have a heart condition and this it could be really dangerous. But generally, it's like, well, we could try something different. If it doesn't feel better, we can always go back to the thing that you love and feel is really good. So, we're not saying you have to come off of this medication and go on to something different. We're here to offer our clinical perspective. And the patient has all the autonomy to choose to follow our treatment recommendations or not.
You have just been awesome. You've been such a great guest, and
Thank you. This is
we could be
wonderful.
here for hours. And
Absolutely.
the thing that I really love about you and your team, and I think that comes through in this interview, is just again how broad of a perspective you take, how individualized you are. You're such a tailor. So is your team. You do great collaborative work, of course, with me and other folks that you work with. And there's no ego with you, and it's very empowering. And
Thank you.
there's you and the client, irrespective of their age and or the parent, or if it's a young adult or an adult. It really is a team approach, and something that, again, they have a lot of voice and choice in. And you do such a good job of, again, not asking people to, asking people to look again at things they can and cannot control and then lean in. And, the med is one piece of a larger
Mhm.
wellness plan. So just
Absolutely.
last question. And before I ask that, and again, I will put ways that folks can get your website in the description, but just real quick, just shout out if someone's interested in reaching out and finding out more information about how they can get some top of the line, best in class, psych support, med management, Med-Eval through you and your team. How would they go about that?
The fastest way to contact us would be to go onto our website. It's www.safeharborpsych.com. You can request an appointment directly through our website. And we get that request usually within minutes. And then we can schedule intake evaluations that way. We can set up a screening call if somebody has questions about whether they might be an appropriate fit for our services and feels like they want to have a conversation with myself or one of the other clinicians just to get a sense of whether it makes sense to set up an appointment. You can also request a screening call that way as well.
Cool. And for folks listening, please, if you haven't already, head over to fourpeaksparents.com to sign up for the newsletter. If you, of course, ever want to learn more about the program, please reach out to me directly. We can have a discovery call. And if you ever have any idea for a topic for the show, I'm all ears. A lot of the guests, we have a guest, my next guest is someone's going to talk about blended families and what that journey looks like, which I think is such a good topic to dive into. But Carly, thank you so, so, so much. And just one little last thing. Now that you're a mom, I'd love to just hear like one sentence or two of like how your perspective has shifted now that you're a mom. Could be 5 sentences. Let me not pin you to one or two. What in essence, like, what is the shift that's transpired going from having treated teens and kids forever, and now you're a mom? What's different? What's been expanded in that perspective?
The sleep deprivation that happens when you're a
Mm-hmm.
parent is like so different than just
Yes.
insomnia, and then
Mm-hmm.
being expected to like parent perfectly after not
Mm-hmm.
having slept, after
Mm-hmm.
taking care
Mm-hmm.
of a child all night
Yep.
is so real and it's so
Yep.
hard. And I'd like to think that I always empathized and understood, but I don't think I really fully appreciated everything that parents, especially new parents, are going through with just not sleeping at all and then expected to be your best the next day,
Yes.
expected to have perfect emotional control, be great at your
Mm-hmm.
job, and then parent perfectly as well.
And six-pack abs. Don't forget about six-pack
Right, right,
abs.
right.
Yeah.
And make it to the gym and,
Yes.
cook
Yes.
chef grade meals.
The wear and tear of parenting.
Oh, for
Um,
sure.
well, I can't thank you enough.
Thank you.
You do such amazing work, and it's such a honor to get to work alongside you and call you a colleague.
Likewise.
And I just thank you so much. I hope this was helpful to everybody. I can't wait to hear folks, any kind of reactions or thoughts about it. And also, I will see everyone in the next episode. Everyone have an amazing day. Be well. Hey everyone, Thomas here. First off, it means the world to me that you took the time to listen to my podcast. Thank you from the bottom of my heart. Also, if you want to receive the latest podcast updates, as well as expert parenting tips and practical strategies for navigating your tween, teen, or young adults challenges directly to your inbox, then sign up for my newsletter. The link is in the description. And most importantly, if you're tired of feeling overwhelmed, stuck, stressed, and are losing sleep because you're constantly worried about your tween, teen, or young adult, your first step is to realize that you still have a choice and can do something about it. I'm ready to help you take action and create the results you desire today. Just go to 4peaksparents.com and book a free strategy call. Let's do this. Last thing, while you were listening to this show, who was the one person that you thought could really benefit from hearing it? Please share it with them.